Hello and welcome everyone to session 1 of the Untold Stories, COVID-19 and UIO's Community of Learning. This session is entitled Addressing Urban American Indian and Alaska Native COVID-19 Data Gaps to Improve Health Equity. Please enter your name, organization, and tribal affiliation as you enter the Zoom room. We will start shortly. Next slide. To begin, we have a background on NCUIH. The National Council of Urban Indian Health, NCUIH, is a national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives living in urban areas. NCUIH is the only national representative of the 41 Title V UIOs under the IHS and the Indian Healthcare Improvement Act. NCUIH strives to improve the health of over 70% of the American Indian and Alaska Native population that lives in urban areas, supported by quality, accessible healthcare centers. And here are some of the UIO locations. Welcome. We will start with quick introductions and then delve into the UIO and COVID data topic. We'll conclude with a quick knowledge check and Q&A discussion, after which we will provide announcements about NCUIH's upcoming events. Before we begin, please note that this session will be recorded for educational and quality improvement purposes. NCUIH will be utilizing the recording to continue to share and educate frontline healthcare workers throughout this pandemic. All mics have been muted. Please turn your camera on to allow for interaction. This is a 1-hour session. Questions can be entered into the chat box. Q&A session will be offered at the end of the session, and slides and recording will be available at a link on our webpage. There will also be an evaluation to follow at the end of the session. We welcome your feedback. If you do have any IT difficulty during today's call, please chat directly to comms and events in the direct chat, and they can assist you. Finally, if you could, please enter your name, UIO, or external organization, and any tribal affiliations into the chat box so that we can get to know each other and count your attendance. To ask a question in the chat box, select chat at the bottom of your Zoom screen. Then type your question or comment into the chat box that will appear on the right. Your feedback is important, so please don't forget to take our survey to help us improve our services to you. As a way to measure the session outcomes, we will conduct a brief knowledge check during our session. We will show polling items on the screen and ask for your replies. Are we good to move on? Yep, okay. Next slide. Thank you. After we share the introductions of today's presenters, our session will begin with our first presentation. Now, to introduce our presenters. Alexander Zemo. Alexander Zemo is an experienced statistician, having worked at all points and aspects of the research process. He received his Master's of Science in Statistics from American University in Washington, D.C., having worked on 30 peer-reviewed articles on numerous health-related topics. At NCUIH, Alexander works in webinar evaluation, COVID-19 tracking using national databases, census resources, and relational reference files, leveraging statistics and data visualization for biweekly reporting and data journalism. Scott Erickson. Scott Erickson is an epidemiologist at the Urban Indian Health Institute, a division of the Seattle Indian Health Board. He received his Master's of Public Health Epidemiology from the University of Washington School of Public Health. Prior to beginning working at UIHI, Scott's research focused on improving hospital discharge outcomes of pediatric patients with severe traumatic brain injury. At UIHI, Scott has worked on the community health profiles and diabetes projects and currently serves as lead epidemiologist on projects analyzing national COVID-19 case surveillance data. His work contributed to the generation of the report titled Data Genocide of American Indians and Alaska Natives in COVID-19 Data, which was designed to spotlight the erasure of American Indian and Alaska Native persons from COVID-19 data. Next slide. Ladies and gentlemen, now our presentations.
Good afternoon and welcome to this presentation. Thank you very much, Sabrina, for that introduction. Again, my name is Alexander Zemo and I'm a statistician here working on NCUIH within the research division, and I would like to present some of my work that I've been working on. The learning objectives for this part of the presentation are as follows. First, we will explore the current state of the pandemic in UIO service areas and compare it with the pandemic as it has evolved. Second, we will use metrics of social vulnerability to demonstrate that urban AIN communities are at a greater vulnerability than their white neighbors to the impact of the pandemic. And finally, we will show that though the available data shows a picture about the pandemic, there are a number of sources of inaccuracy resulting in the data failing to completely illustrate the full extent of the pandemic in urban AIN communities. Next slide, please. Here is an outline of the presentation. First, we will briefly discuss the data sources and methodologies employed in this analysis. Following, we will discuss the findings as listed in the learning objectives. This will transition to Scott to continue to talk about the issues with data and how we can address these challenges. Next slide. First, the data. The data used to estimate the population of urban AIN people is from the American Community Survey 2015. These are counts of county-level self-reported American Indian and Alaska Native alone or in combination race. Census information is then merged with a COVID-19 database compiled by the Johns Hopkins University Coronavirus Resource Center. JHU compiles COVID-19 confirmed cases and death statistics published by county and state departments of health and updates their database daily. Lastly, these demographic and COVID-19 data are merged with a reference database on COVID-19 Community Vulnerability Index. This is a variation of the CDC's Social Vulnerability Index that was developed by Sergo Ventures and has been utilized by the CDC and other organizations in some of their reporting. Next slide, please. The key variable of our analysis was the newly confirmed COVID-19 cases and deaths. For each county in a UIO service area, new 14-day COVID-19 cases were computed each week, as were new COVID-19 deaths. 14-day new cases and new deaths are then summed across counties within the same UIO service area, which are based off of the service areas as defined on the Urban Indian Health Program profile. Transmission rates are then estimated by dividing by the total population of the service area and multiplying by 100,000. Maps and line plots using these statistics illustrate the spatial and temporal development of the pandemic. Additionally, counties are also ranked by new 14-day cases and 14-day deaths. For each service area, the county with the highest rank in each service area is selected as the service area's new case and new death rank for that week. These ranks are plotted and tabulated to determine how often a service area remains at a particular relative rank. Next slide, please. Additionally, we will simultaneously look at the Social Vulnerability Index, the estimate of AIN population, and the cumulative COVID-19 cases. An area under the curve methodology was used to analyze the relationship of social vulnerability and AIN population, which was also illustrated with tables and bar charts. Please. So first, the current lay of the land with regards to COVID-19 pandemic in UIO areas. I would like to demonstrate that one, UIOs are right now in the hotspots of the pandemic. Two, that when the pandemic was at its worst, UIOs were still in the hardest hit places. And three, UIOs have persistently been in hotspots throughout the entire pandemic. As of March 28th, the county with the most new cases of COVID-19 was Kings County, New York, within the New York City service area with over 17,000 new cases. Equally, three new other counties in the New York service area were in the top 10 counties as the area was experiencing a resurgence in cases. The county with the most new 14-day deaths was Los Angeles County. The counties that are listed in red are within UIO service areas, showing that based on recent data, UIOs are in the hottest of hotspots. Please. The map here illustrates the 38 service areas in the UIO network, and the counties are colored by the number of new 14-day COVID cases as of March 28th, with the top 10 counties in darkest purple, followed by the top 1%, then the top 100. There are 3 UIOs within the top 10 counties, 3 more UIOs in the top 1% of counties, and 25 more UIOs in the top 100 counties with new cases. Additionally, many UIOs are currently operating in areas of high transmission risk. Shown in this map are all the counties colored by the number of new 14-day cases per 100,000 population. As of March 28th, there are 11 service areas where the transmission rate was at the high risk category of over 200 new cases per 100,000 population, circled in blue. Or they should have been circled in blue. Can you please progress? Here is pictured the counties with the most new deaths in the period between March 14th and March 28th. COVID deaths tend to represent prior conditions, such as a surge in new cases in previous weeks or even months, since incubation and longer hospitalizations may lag a surge of new deaths from a surge of new cases. This is particularly noteworthy since Los Angeles County has been ranked first in terms of new cases for nearly all of December, January, and February. Progress, please. Shown here is a bar graph displaying the total number of cumulative cases since February 9th, 2020 in all UIO service areas and comparing it to the national county average and average of urban counties. Says service areas denoted with an asterisk are service areas that are only one county. Aggregating service areas in terms of their cumulative cases, UIOs are present in areas with very high cumulative totals, with Los Angeles by far the most number of cases, 55 times that of the average among urban counties. All but 6 service areas surpass the average of urban counties, which include 10 single county service areas. After scaling for population, the Sioux Falls service area shows the highest rate of cumulative cases. Additionally, 19 service areas of 38 are above the national average, and 22 are higher than the urban county average. Beyond recent numbers, UIOs have been faced with the heaviest burden of the pandemic throughout the pandemic. Shown here is the trajectory of 2-week transmission rates for each UIO service area. The red line denotes a 14-day transmission rate of 200 new cases per 100,000, marking a high risk of transmission. As the hotspots of the pandemic shifts across the country, each UIO finds itself as a critical hotspot at some point. For instance, service areas such as New York had a very early spike in transmission rate as the pandemic was new in April 2020, while Phoenix service area saw a spike in transmission rate around June. Uniformly, though, all service areas saw a surge in high transmission in November to January. All 38 service areas reached their peak transmission rate at this time, 32 of which had rates greater than 1,000 new cases per 100,000 at their peak. The peak of the winter spike was different between UIOs, though, with some service areas such as Billings, Omaha, and Salt Lake City experiencing it as a continuation of a spike in autumn, while others, such as Bakersfield, were a resurgence from a previous spike. Even still, there are areas that have felt these surges in new cases more acutely, such as Silverbow County or the Reno service area, where in December, the 14-day transmission rate approached 3,000 new cases per 100,000 population, exceeding the transmission rate of Los Angeles County in the same week that Los Angeles saw 200,364 new cases within 14 days. Let's progress. Lastly, UIOs are persistently in the highest impact areas. Shown here are trajectory plots for the rank of selected service areas based on the new cases in the last 14 days. The red line is the top 10 counties. The gold is the threshold for the top 1%. The black line is the threshold for the top 100 counties, and the gray line is the top 10% of counties. As shown here, some service areas have stayed persistently the highest rank in terms of new cases. Until recently, Los Angeles County was in the top 10 counties for 11 months. At the same time, other UIOs areas experienced moments of large surges in new cases, such as the Sioux Falls service area, which despite its size, reached 34th place in November 1st of 2020, just missing out on the top 1%. Now to show that even in an urban environment, geography correlates with additional vulnerability for urban AIN populations, increasing the impact of the pandemic and increasing the burden that UIOs need to bear to service their populations. COVID-19 Community Vulnerability Index is a variation of the CDC's Social Vulnerability Index, or the SVI. The SVI is a metric that attempts to estimate a location's resilience to hazardous events such as natural disasters, and can be used to identify areas of extreme need and plan for emergency preparedness. The CDC selected 15 indicators associated with community vulnerability divided into 4 subdomains: socioeconomic, household composition and disability, minority and language demographics, and household type and transportation. The CCVI adds 2 additional subdomains: epidemiological factors specific to COVID-19 resilience, such as percentage of COVID-19 risk factors and population density, as well as health systems factors such as health spending and resources. The first 4 domains that constitute the SVI are available at the census tract and county level, while the epi and systems factors are reported at the county level only. Next slide. Each tract and county are ordered and assigned their percentile ranking for a CCVI and each subdomain, as shown in the red matrix. The cells are shaded by quartile, with the brightest red meaning the county is within the top 20 percentile of that domain, and the palest being that it is in the lowest 20 percentile. Shown here are all the counties of California, with the estimated urban AIN population living there, along with the cumulative cases per 100,000 on the right. This and the following pages show the other service areas in the same format, which you can use as a reference, demonstrating the convergence of areas where urban AIN population is highest, correlating with increased vulnerability and greater COVID-19 impact. Take, for example, the Oakland service area, which is comprised of 5 counties. All of these counties have a high number of cumulative cases, with Alameda County having 83,000 cases over the year and Contra Costa having 65,000. Note that these 2 counties in Oakland service area have the majority of the service area's urban AIM population. At the same time, these 2 counties have the highest and second highest CCVI in the service area. We further concede that this is explainable by the higher health systems vulnerability and, to a lesser extent, SES vulnerability. Next slide, please. Even at the county level, the relationship starts to appear, with areas with high CCVI also bearing a heavy COVID-19 burden. This also then puts additional risk on the urban AIN people that live in those areas, such as some of which boast substantial populations, particularly because urban AIN tend to live in more vulnerable areas within each of these communities. Next slide, please. This brings up one of the shortfalls of the counties using county statistics. It is not specific enough for urban AIN populations. Take, for example, Silverbow. County-wide, the CCVI is very low with 0.07. However, the single census tract with the greatest COVID-19 vulnerability contains nearly half of the county's AIN population, and combining the top two most vulnerable census tracts accounts for 2/3 of the county's AIN population. Next slide, please. This phenomenon is also seen in large cities as well. In Maricopa County, a county with persistently high new cases and new deaths, as well as sizable urban AIN population, and the overall vulnerability is relatively low. However, census tract CCVI in Maricopa County ranges from 0.004 to the 92nd percentile, and urban AIN people tend to live in the more vulnerable areas. 19.9% of the county's AIN population lives in the 100 most vulnerable census tracts, where only 10% of the county's white population live. Ultimately, variation in social vulnerability in UIO service areas adds additional risk to urban AIN populations, particularly in areas that are persistent hotspots. Finally, we turn to limitations of this analysis and where our illustrations of the pandemic in the UIO service areas tends to fall short. First, there is a problem of racial misclassification in death records. CDC estimates that the COVID-19 mortality among AIN population was 3.5 times higher than that of the white population. However, it has been shown that historically, death certificates have chronically misclassified AIN people, most often as white. Between 1979 and 2011, less than half of AIN decedents were also classified as AIN on their death records. Furthermore, we expect that AIN decedents who die of COVID-19 related causes are more likely than white people to have their cause of death not recorded as COVID-19. Analysis shows that racial misclassification of AIN people on death records are more common in urban areas, and this two-pronged error is likely to understate AIN COVID-19 mortality rate. Furthermore, relying on COVID statistics for COVID-19 cases and deaths cannot give an accurate picture of the extent of the pandemic for urban AIN communities. As we mentioned before, urban AIN people are dispersed throughout the cities, often in areas that are more vulnerable to the impact of the pandemic. Take, for example, the Los Angeles area. There is an estimated urban AIN population of 156,000 people spread across the county, as seen as the green figure, and the urban AIN population tends to live in the more vulnerable census tracts shown in the blue. However, there's only one number for COVID-19 cases and deaths applied universally to the entire county. Next slide. If we look at service areas such as Dallas, which encompasses multiple counties, we can illustrate the point that greater granularity can improve our understanding of the pandemic for urban AIN populations. You can see in the table and in the green figure that urban AIN people are dispersed throughout the city, with a substantial population of the service area's population living in the county with the most cumulative cases of COVID-19. This is further linked with the social vulnerability, as most AIN people as a proportion of their population live in the most vulnerable census tracts compared to white population. If you would like to see more information on the information I have presented here, if you are a NCUIH UIO member, you can download a bi-weekly UIO COVID-19 tracking report on NCUIH's Knowledge Resource Center. We will be posting this most recent analysis shortly. Additionally, keep an eye out for our blog posts on NCUIH's website providing statistics and visualizations of the COVID-19 pandemic in UIO service areas. Next slide. To summarize, UIOs have been on the front lines, in the highest risk areas, now and throughout the pandemic. Urban AIN populations live in areas that are more vulnerable to the impact of the pandemic, thereby increasing the challenges and burdens that UIOs bear. And issues with data quality, availability, reliability, and structure prevent us from completely and clearly articulating the extent of the pandemic, specifically for urban AIN communities. Thank you very much, and I'm open for questions.
All right, thank you, Alec, and now we shall begin our Q&A.
Alex, we keep our eye on the chat box as well for participants who may enter their questions into the chat box. We also have the capacity to unmute a participant if they choose to raise their hand. So we'll keep our eye out for either option. Again, we have a few minutes for Q&A. It's been a lot of information to digest. It's worth noting that we'll close with a Q&A session at the end of Scott's presentation as well. So for those of you, again, who have a question that occurs to you as we go through the second presentation, feel free to enter your question into the chat box and we'll keep track of those questions, or you can save it for the Q&A session that will come at the end of Scott's presentation. There's a question from Francie Spencer. She asked if there'll be access to the slides, and the answer for participants is yes. Slides will be available and shared as a link shortly after this presentation, and available to all of our participants via email. We'll send a link to not only the slides, but also to the Zoom recording of this presentation. So the answer for all of you is that the slides will be made available. Having said that, if we can go ahead and start with Scott's presentation, I think we'll be in good shape. Thank you.
Hello, everyone. I hope you are having a great week so far. My name is Scott Erickson. I've been working as an epidemiologist with UIHI for some time now, since UIHI began receiving COVID-19 data from the Center for Disease Control and Prevention back in July of 2020. And I've been working to generate meaningful findings for urban American Indian and Alaska Natives since that time. Unfortunately, due to the low quality of racial information in COVID-19 data that the CDC is able to obtain, this analysis has been forced to focus on the extent to which there are enormous gaps. As of today, if you go to the CDC's COVID tracker, you can see that only 61% of all COVID-19 cases since the start of the pandemic have complete race or ethnicity. In this presentation, I'll present an overview of what we know so far and the impacts of COVID-19 on urban American Indian and Alaska Natives, and what the gaps in our knowledge are. Next slide, please. Starting from the beginning, after the first confirmed COVID-19 case in the US on January 19th, 2020, UIHI was not provided access to CDC data until July 2020. Almost immediately, we began to notice flagrant issues with the completeness of race and ethnicity in this data. Around September, the CDC began putting a notification on their COVID tracker dashboard, which you can see today, that the CDC is working with the states to provide more information on race and ethnicity for reported cases, and that the percentage of reported cases that include race and ethnicity information is increasing. However, as you will see on a slide that's coming up, this change has been glacial at best. And in February of 2021, UIHI put out the Data Genocide Report designed to help spotlight these issues. Next slide, please. I'm going to launch into providing our most up-to-date numbers now on the impact of COVID-19 on urban American Indian and Alaska Native people. However, to be a good epidemiologist, I need to operationalize some of our terms and provide a brief overview of the gaps in the data. First off, for the numbers I'm going to present on the upcoming slides, I'm going to define urban. Urban center is defined by the National Center for Health Statistics based on the urban-rural continuum scheme, separates counties into urban and rural based on the total population. For your reference, the map shown here indicates urban counties as shown in any shade of green. Of note, there are only a few counties that are reporting race and ethnicity with greater than 70% completion of data. I use this cutoff because this is the cutoff that has been used in previous morbidity and mortality weekly reports in the CDC publications as adequate reporting of race and ethnicity. You may note that the counties that are shaded in light green, which indicates a greater than 70% completion of race and ethnicity, are only a small subsection of all urban counties, less than 1 in 4. I also want to define what I mean by completeness of data. For our purposes, complete racial data conforms to standards set by the Office of Management and Budget Standards in 1995. Data needs to allow for individuals to select one or more multiple racial identities, which would include AIN, Asian, Black, Native Hawaiian, Pacific Islander, or white, and they should separate the collection of race from the collection of ethnicities. You may notice some patterns here on this map. Several states are overall wholly inadequate in their reporting of race and ethnicity to the CDC. For example, the entire state of California does not present, any county is not presenting cases to the CDC with greater than 70% completion of race and ethnicity. Additionally, to add additional context to this graph, the reporting of this information to the CDC is completely voluntary, and some states have opted out. A good example of this is Texas, where as of today, we have only 5% of the total cases in Texas. In summary, the data that the CDC has on collecting detailed information of COVID-19 cases on all individuals in the US is spotty by states, and it is not wholly representative of all people. Next slide, please. With this being said, here's our current best estimates at the total number of the impact of COVID-19 among urban, American Indian, Alaska Native persons since the beginning of the pandemic. These numbers come directly from the CDC's National COVID-19 Case Surveillance Dataset as of April 20th, 2021. I should note that we know that these numbers are a gross undercount of the total burden of disease. They do not count all of the reasons that I listed before, where states are not either sending in data with complete racial information or they are not simply collecting information at all. In this, in the analysis that I'm presenting now, we will define American Indian, Alaska Native as a person who lists any of their racial identities as American Indian, Alaska Native, regardless of their ethnicity. To date, we have identified 162,306 urban American Indian, Alaska Native COVID-19 cases, 9,626 total hospitalizations, and 2,482 known deaths in the COVID-19 case surveillance. To the right is a epidemiologic curve I've created where by week we have tabulated the total number of COVID-19 cases among urban American Indian Alaska Natives. As you can see, if you're familiar with other epidemiology curves, this mirrors the overall presentation of the disease with an initial first surge in June and then the big holiday surge that happened around November to December. Next slide, please. I wanted to take a brief step backwards to look at the overall completion of race and ethnicity over time. I wanted to present the completion of race and ethnicity over time to mirror that initial epidemiologic curve I presented. And you may notice around November and December on this graph of 2020, a sharp decline in the total percentage of cases with complete race and ethnicity information over time. This reflects straining health systems, trying to keep up with the burden of cases and being unable to investigate race and ethnicity for all COVID-19 cases that they were receiving. Unfortunately, what this means is that during the surges that happen, we have some of the lowest quality of racial information that has happened since the start. You are also able to see that since the start in April, that there has been a slight increase in the total percentage of cases that are reported to the CDC on a given day with complete race and ethnicity information. Started at, if we look at complete race and ethnicity information, it started around 40%, and now it is currently up around 50%. That's a total of 10% change over 12 months. And as I said before, I feel that is positively glacial. Next slide, please. To present a more focused analysis and prepared, I'm going to shift our focus to counties served by an urban Indian health organization. This analysis is focused on the best extent of our knowledge pre-winter surge. And in order to standardize definition across the state, I have to focus our analysis on individuals who list any of their racial identities as American Indian, Alaska Native but we need to only focus our analysis on those who list themselves as non-Hispanic. Next slide, please. Based on this analysis, we identified a total of 22,389 COVID-19 cases among urban American Indian Alaska Native individuals. At that time, the cumulative incidence of COVID-19 among non-Hispanic American Indian Alaska Natives was 2,900 per 100,000, compared to the rate among non-Hispanic whites, which was 1,431 per 100,000. This led to a relative risk of COVID-19 among urban American Indian Alaska Natives of a twofold likelihood of contracting COVID-19 compared to non-Hispanic white individuals. Next slide, please. Breaking down the demographics, we can see a marked increase in the relative risk of COVID-19 by age. One important addendum here is that urban American Indian Alaska Natives are a younger population than non-Hispanic whites living in urban settings. As such, it's not surprising to see that once we investigate within age demographics, that the overall relative risk changes. Here we can see that within the demographics of 0 to 19, the relative risk of contracting COVID-19 is actually 3.6 times that among urban non-Hispanic whites. We see similar patterns happen among those aged 20 to 44, age 45 to 54, and 55 and up. A similar higher risk within the age group, indicating that there was some confounding that happens if you do not adjust for age when you're looking at your analysis of overall rates among urban American Indian Alaska Natives. We can also identify that within male and female strata, that the relative risk of COVID-19 remains to be roughly twice that among non-Hispanic whites. Next slide, please. Breaking down a county by county inspection of COVID-19 incidence and disparities. This is a fairly complex graph, but bear with me. As I'll go through that. On the x-axis, we have the cumulative incidence of COVID-19 per 100,000 urban American Indian Alaska Native individuals in that county. I use this to identify counties where a large proportion of that population has been infected. For instance, on the graph, you can see that dashed line that is running vertically at around 2,500. That is the average rate of COVID-19 among urban American Indians, Alaska Natives pre-winter surge. Counties to the right of that line experienced higher rates of COVID-19 infection among urban American Indians, Alaska Native populations than the average. On the y-axis, I have plotted the relative risk of COVID-19 among urban American Indians, Alaska Natives compared to non-Hispanic whites. Counties that are higher than 1 indicate counties where urban American Indians, Alaska Natives were disproportionately affected by COVID-19 relative to non-Hispanic whites. Using this graph, we can see that there are several counties that stand out in terms of the total proportion of the population that was infected. Counties such as Bighorn, Montana, Anchorage, Alaska. It's fairly small in the graph now, but I cannot see that one, but we'll go to Yellowstone, Montana. From the relative risk perspective, we can see that counties in New Mexico were deeply disproportionately affected with a rate of roughly 8 times higher of COVID-19 incidence among urban American Indians, Alaska Natives in Sandoval, New Mexico, and Bernalillo, New Mexico. One other additional confusing portion of this graph is I have scaled the points and the text size based on the total number of COVID-19 cases that happened in that county at that time. The counties with the greatest total number of COVID-19 cases among urban American Indians, Alaska Native individuals was Maricopa County, Anchorage, Alaska, and Coconina, Arizona. Next slide, please. Again, another graph that is, in my mind, I made meaninglessly complicated, but this graph plots the overall relative risk of infection among urban American Indians, Alaska Natives by week compared to non-Hispanic whites by week since the start of the COVID-19 pandemic. I then performed statistical testing by week on these analysis, and we can observe that if you look at the colored bars indicate the overall relative risk of COVID-19 compared to non-Hispanic whites. The more dashed bars that extend beyond the column and below the column indicate statistical significance. From this graph, we can see that urban American Indians, Alaska Natives have experienced disproportionate impacts of COVID-19 compared to non-Hispanic whites since the start of the pandemic. And this has been statistically significant every week up until that period pre-surge. Next slide, please. Even with all this knowledge that we have on these findings, it is deeply important to stress that this data does not reflect every individual in the system. To address this finding, we developed the Data Genocide Report. This report looks at the two best sources of racial information during COVID-19, which come from the state health departments on their COVID-19 dashboards and the data that those health departments report to the CDC. As such, we work to develop metrics that examine the collection and reporting of race and ethnicity by each of these sources. The key metrics we ended up deciding on were, first, were American Indians, Alaska Natives included on the state dashboard in their own category? We did run into one state which lumped American Indians, Alaska Natives explicitly with the Asian racial group. And that was South Carolina, and we still don't understand why they did that. Other states lumped American Indians, Alaska Natives in with a group titled multiracial or other categories. They were not given credit in this category. The second metric we chose were what percentage of cases had complete racial data presented on their dashboard. And again, going back to our OMB standards of classification, we required that the states not have categories that were listed as multi-race, other, or unknown that did not allow for individuals to disaggregate those multi-race or other categories, because lumping someone into multi-race or other eliminates our ability to detect urban American Indians, Alaska Natives on that dashboard. Third, looking at the CDC information, we had to identify a metric by which what percentage of the cases that the state reported were going to the CDC. We needed to develop this metric to identify situations like Texas, where Texas has a large proportion of the US cases, but it sends almost none of those to the CDC. Fourth, we needed to identify what percentage of cases had complete racial information after the data was reported to the CDC. We aggregated these metrics, weighting each of them equally by 25% and weighted them on a scale from 0 to 100. We then assigned each state a grade based on a standard academic letter grading system, and we defined a state as failing in presenting information on urban American Indians and Alaska Natives if their overall grade fell below a 70%. Next slide, please. Our key findings overall was that the US had a very poor rating of a D plus, or 69%. 22 states had a failing grade of less than 70% reporting on all overall categories. 18 states reported less than 70% of confirmed cases to CDC. 14 states did not include urban American Indians, Alaska Natives on their dashboard. And several states fell below that 50% highlighted in the F, including Texas, New York, New Hampshire, Maryland, and West Virginia. Next slide, please. The implications of incomplete racial data on urban American Indians, Alaska Natives is that equity will not be achieved in COVID-19 response or vaccinations until race ethnicity is properly connected and reported. Continual erasure of urban American Indians, Alaska Natives reports, publications, and literatures results in underestimation of the true severity of morbidity and mortality. An inadequate public health program and activity that are non-responsive to urban American Indian, Alaska Native communities. Inequitable allocation of resources for disproportionately impacted communities, incorrect and limited understanding of racial health disparities, and perpetuation of health disparities due to misinformed, data-driven decisions. Next slide, please. UIHI has developed some recommendations for improving the collection and reporting of race and ethnicity. States and federal government agencies have the most power to enact and enforce data quality, policies, and standards. We should mandate the collection and reporting of race and ethnicity for all COVID-19 cases. We should enforce the collection and reporting of race and ethnicity by providing resources, incentives, and penalties. We should resource the overall public health surveillance systems nationally. We must standardize the collection and reporting of race and ethnicity by UIHI best practices, a document that we put out a little while ago that is located on our dashboard. We must avoid grouping population into homogenizing categories such as other, and we must disaggregate the multiracial category. Next slide, please. We have some upcoming analysis coming out. We will be generating reports specific to our urban Indian organizations and their service areas based very much on the analysis that I showed regarding the pre-winter surge. I hope to do all of those reports for each urban Indian health organization and develop a site report that can be used by reports. Next, we have a morbidity and mortality weekly report that we will be submitting for publication soon. This will be a deep dive on the impacts of COVID-19 among urban American Indian Alaska Native people. Finally, we will also be pushing out a data dashboard for CDC COVID-19 data that will hopefully provide a week-by-week updated tool for urban Indian health organizations to track the impact of COVID-19 on American Indian Alaska Native persons in their state, both on a statewide basis and in an all urban county basis. Next slide, please. That is the end of my report. If you have any questions or comments, please feel free to reach out to me at any time. Thank you very much.
Thank you, Scott. And now we shall begin our Q&A.
Again, you can feel free to enter your question into the chat box, or by raising your hand, request to be unmuted. I have a general question, and maybe either of you could address it. I'm curious if the problem of the absence of race reporting has accelerated. Or is it greater now since the pandemic begun, or is this just representative of how it's always been an issue with the collection of racial data for American Indian and Alaska Natives?
I'll take a stab at this. My impression from my colleagues who have more experience is that this has been an issue longstanding over time. And this is actually the best that the collection of race and ethnicity has been at a statewide and a nationwide basis for a long time. The COVID-19 put an enormous burden on health systems to meet the collection, to constraining their ability to collect the race and ethnicity information. However, this is the first time there's been such a strong push to collect race and ethnicity in this capacity nationwide.
Thank you, Scott.
In that case, I think we're good to move on to the knowledge check. All right. So as a reminder, as a way to measure the session outcomes, we will conduct a brief knowledge check during the session.
Just as a reminder, NCUIH participants are asked to not provide answers in the polling. This is for our registered members in the audience only, as an assessment. Thank you. I would want to share an observation entered into the chat that the artwork that's part of the presentation, the polling and the slides, is being credited. So there's a general acknowledgement of the quality of the artwork. Thank you so much, Angela. Appreciate that. Angela Young had that observation.
All right, and just to wrap things up, I would like to thank our audience for joining us this afternoon. I would like to remind you to click on the link for our session survey. Your feedback about the session is very important to us. And finally, I'd like to invite you all to our second session on April 27th. It's the UIO COVID-19 Experiences, a spotlight on UIO best practices and lessons learned. Again, thank you so much, everyone, and have a good afternoon.